She has absolutely beautiful cheeks. They're still holding up. When did we inject them? 2 years ago? Maybe more, huh? More than that. So they're holding. A lot of it is bone structure. I can't take credit for it, but still there's product that's there, and we can talk about why products last so long. It's what they do biologically that lasts long, okay? And we can talk about that afterwards, but I'm going to show you how I do it. I have a patient that comes in like this, and I told you she's a 9.5 out of 10. Sorry to take off the 0.5. And and I want to make sure that I don't downgrade her. I have 0.5 to make her better, 9.5 to make her worse. I got to be dead on. When I look at the face, can I have the white marker, please? I look at the face and I'm saying to myself, okay, what does her cheek need? Damn it doesn't need much, but she can use a little bit around here. There's no question that she has a little bit of the infraorbital crescent, which we're going to treat, okay? I don't see any flatness over here. She's doing well. Everything looks pretty good. Would I walk away from that cheek? Never. So what I'm going to do is I'm going to find out if I'm missing something, and this is why I do this marking on patients especially who seem to have really beautiful cheeks. I go from the lateral canthus to the oral commissure. Straight line, okay? As straight as I can draw it. Let's turn you a bit like this. This is called Hinderer's line. Hinderer was a plastic surgeon from Germany who said, if you're going to put in a cheek implant, make sure that you don't put an implant in any closer to the nose than this line, or they're going to look like Cirque du Soleil. I don't think he used that expression, but that's basically what happens. They get too puffy in front. So we use the same marking as if I was going to do surgery on her. And then I draw a line that goes from the mid-tragus straight across to the mouth. Corner of the mouth, commissure, to mid-tragus. Where did I find this line? I'll tell you a little story because I'm all about stories. You know that. And then I draw a horizontal line like this. In theory, if I was to measure her, this would be 1, this would be 1, this would be 1.618, a golden triangle. But I'm not talking about that. I spent 3 terrible days of my life at a modeling agency measuring models. It was the worst 3 days I've ever had. I suffered immensely. And what I was looking for was to try to figure out where is their cheek oval. Remember I told you it's an oval, not a circle. And if you draw in the oval over here like this, this is her ideal cheek for her face. What is it doing? It's telling me that for the position of her eyes, her mouth, her ear, the height of her face, the width of her face, this is pretty much where the oval should be, because when I started drawing it out on all these models, that's where it was, independent of their face type or their face architecture. Once I do this, okay, and you're looking, once I do this, I'm now not distracted by the rest of her beauty. So all this has disappeared, and all I'm seeing is the oval, and I'm saying, do I have a perfectly smooth Fabergé egg over here? And now when I turn her from side to side, I see that she's actually a little flat over here, and she has a little flatness over here. I don't know if you can appreciate that, but we're going to look, and you might see it there, okay? So I say to myself, okay, I now have 2 areas to adjust. If it was a wider, a bigger area, out comes the cannula. I'm giving the face what it's telling me it wants. This is the it wants part. Can I have that contour again? Okay. So what we're going to do is we're going to go ahead and correct this little area and this little area. Now she's going to have a smooth egg. But then I have to see if I have the right width to her face and if the cheek light reflex is in the right place. Is everybody following along here? They're so quiet.
Was she numb?
No. We did nothing. We didn't give you any numbing cream. I hate that stuff.
You talk about the pain experience, and if you don't feel comfortable, they don't come back. So.
That's right. But let me tell you something. What did you say?
I said there's no pain.
Okay, but there's got to be some pain. So 0 is no pain, and 10 you want to punch Catherine. What was it?
0.
0. It's got to be 0 or a half. She's being very nice to me because she figures I'm going to stop injecting her. Okay. You want it to be between 0 and 1, 0 and 2. If you use the cream, and a lot of people do, if you use the cream, what you're doing is you're using a crutch. And you'll never develop that leg. It'll always be weak. Don't use it as a crutch. Develop non-painful injection techniques. Every time that I put a needle in, you see me pinching the skin upwards into the needle. Not only is it distracting, but it's moving the skin into the needle, which is much less painful. You'll see me do it over here, okay? Every time I'm putting the cannula forward, when I reach a little bit of resistance, I don't force it through. I never force cannulas to go where they don't want to go. I inject a small amount of product, opens the pathway, and I keep on going. Think about ways to be sort of non-aggressive with patients.
Did you do the same with lips?
Absolutely. I haven't blocked lips in probably 10, 12 years. She's going to want her lips done because I remember her. Even though she came in with big, beautiful lips, she kept on saying, "Give me more lips." You want more lips, don't you? Flip them. She wants me to flip them. Okay, we'll flip them. We'll try. I haven't got toxin, but I'll try to flip them with the Russian lip flip if you want. If you want to see that. Yes, yes, yes? You're in, girl. That's it. Okay. So she gave me literally 0.1 over here, but I don't need much. If I'm on bone, I'm going to use bone over here. There's a lot of little vessels. I'm going to try to miss them. You're going to feel a small little stick, little pinch. I go down, I inject, I lift, I do a little double scoop. That's it. Finished. When you do that double scoop, look, there's no bleeding. Why? Because it's what we call in Canada the Z technique and what they call in the US the Z technique. As a nurse, you're taught when you give an injection, you go into the skin, right? You go into the skin, you lift it up, and then you go deeper so that when you inject intramuscular and you pull your needle out, the skin then falls down and tamponades over your injection point. That's what I'm doing. I'm going to use a little mini double scoop over here. Doesn't need much. A little flick. Skin into the needle. Slow injection. Okay? My needle's only in halfway because I'm below the bone. I don't want to be deep over here. Small injection, and then look. Vertical lift. So I'm still inside my first bolus, but I'm just lifting like this, and I'm putting in the rest of the product. Now watch what happens. It just corrects with a small injection. In fact, overcorrected, no bleeding, tap it. I'm not a big musher. I don't like to play with product too much because these high-grade products, they're like Ferraris. What you end up doing is you spin out with them. Thank you. Okay? I'm going to clean her up. Okay. So the idea is when you go down to bone or you're going into the tissue that you're targeting, it might be not bone because there's no bone here. You put your first bolus in, usually at 0.1. You back out by 1 millimeter. You lift 0.1. You back out by 1 millimeter. You lift vertically, so you're still in your bolus, but you're stretching it up, and you put your second bolus of 0.05. What am I doing? What I'm doing, and I thought about this, is like if you're in the gym, and you're lying on your back. You're lying on your back on the bench press board, and you want to push the weights away. So you have these weights, and you're pushing, and you're pushing, and you're struggling, and you're pushing, and you get the weights up like this on your back. The weights are here, but it took you energy to go ahead and do that. When you have to force against something, the tendency is with the product's going to spread because it's pushing against resistance, and it's going to spread out, right? So what I do is I have a spotter, my needle. I'm lying on my back. I have somebody, this very robust young man over here is standing over me. He lifts up the weight to spot for me, and I go, this is cool. I just lock my elbows underneath, and the weight's in the same place, and I haven't done any work. Put your needle into the skin. Go down to bone. Remove it off the skin, and then lift vertically. Look what I'm doing. Lift the sleeve of skin up, and then let the product flow up to the skin. Then you remove your needle, it just settles down on it. And sometimes it looks too high, give it a little press. Within an hour, it's set, it's done. Don't have them lie on their face for an hour, but after that, I can tell them, sleep on your head tonight, I don't care. Okay? So that's the idea behind it. So we corrected those two little spots, and now we have to find out, is her light reflex in the right place? Is the apex in the right place? So we're going to turn her head just 3/4 like this. You can see where the projection of her cheek is. Damn, you held up pretty good. Okay, relax a bit. Her projection is right here. So this is where her light is bouncing off her cheek over here. Okay, very good. This is what I do. I go from the groove of the nose to the top of the tragus, and I draw a straight line that goes across. I do this sometimes, okay, without even, I'm getting good at drawing straight lines. I do this sometimes in my head. Now watch what we do. Hold this. You grab the middle portion, you grab the orbital rim, the lateral orbital rim. There's an inside to the orbital rim, there's an outside, and you take the center part of it right there, and you drop down a vertical line, like that. Okay, that's a plumb line. Now I go ahead and take out my caliper, and let's see if I was pretty decent at this. I measure the distance between her eyes. We got that? I now measure the distance from here to here, and it's exactly that. Do you see that? That's 1.618, but the other way to find it without the caliper is just to do this. I'm moving it a half a centimeter. You got to be kidding. I told her she's doing really well from our injections, even from 2 years ago. Does it make sense to go ahead and to put product in just for that? Let's find out. Like I always say, I'm always curious to see if it makes a difference. I clean the area up. I balance my needle over the area that I'm going to inject. I pull the skin up. I'm still in the same area. I give her a little pinch, and I go down to bone slowly. You can aspirate if you like over here, but this is an arborized area, so it's safer. I start the flow of product. I look at the skin. I glance at the glabella to make sure everything's okay. I now put in what I think is about 0.1. I release and I lift. See how I'm lifting vertically? And I put in 0.05. Done. Out comes the needle. No bleeding. It will bleed once I go ahead and wipe off the little fibrin plug. And I've moved her apex from here to here. It's ridiculous. Why would we even bother doing that? Let's take a look. There's the reason. Which side of the face looks narrower? Which side of the face looks narrower? This part that I just injected. I've added volume to narrow her face. You see? Corner of the mouth, apex of the cheek. Going to use a little bit of more product. Chin down just a bit, love. Let's take a look. What's happening at the nasolabial fold? Everything from here goes here. So we're doing this. Everything from here goes here. So we're doing this. So we're really going to finish her off by doing this. Look how nice that's going to look. So let's have, no, I don't need a marker for this, I don't think. Let me have the calipers just to see, because I want to make sure I have the right facial width. She was a little bit short, and I want to make sure that I have the right facial width here. So we're going to measure her again. There we go. And then we're going to measure her to this thing. It's so close. Okay, I can use one more little injection. I'm going to target the zygomatico-cutaneous ligament over here that's right behind it. Okay, not the zygomatico-cutaneous ligament, sorry, McGregor's patch, the zygomatic ligament. Flesh needle, thank you. I'm going to pull it up, little pinch, down on bone. And this is just a plain flat-out injection of 0.1. It's just to go ahead and to pin things back. It's going to bleed. Oh, it didn't. You're being very nice. And there we go. Now I've really taken the stress off this as much as I can. So what have I done so far? I've used hardly anything on her forehead because she didn't need much. We put in 0.4 into the temple. On the other side, we did a superficial temple. And now I've used 2 injections on her cheek. Actually, I did 2 small injections over here. She only gave me 0.15, so I used 0.15 product there. Now I've used 0.15 and 0.1. So I've used maybe total 0.6 of product. I haven't hit a syringe yet full of product, right? You got the arnica? Okay. Always on the back of your hand. Never take it with your, there it's on the back of her hand, you see? Thank you. Always put it on the back of your hand, never put it on your fingers because your fingers have been touching the patient, but the back of your hand hasn't. So this remains relatively clean. What it does is it can reduce a little bit of swelling, but what I'm using it for is for the proprioception, to feel if I left her a little speed bump over there, I want to make sure that she's nice and smooth. So I'm using my fingers to feel for what my eyes can see. And that's why I do it. But patients love arnica. You can use ultrasound gel, But when they hear arnica, oh, I know, you're trying to prevent bruising. Sure. If you take the 5 tabs under your tongue 5 times a day for a day or two beforehand, maybe it does something. I'm not going to get into a fight with my homeopathy people over here. I think it probably does help. But topically, it's been shown that it doesn't make a difference with bruising. Let's pan out a little bit again. Yeah, there we go. Narrower up. That's exactly what I want. And the bottom part of the face is tightening up over here too, and I'm even seeing a little bit of an upturn of the mouth. Good. Give me the same product that I just used on the same needle, 27. You have some left. So I'll use the shape, and I'm going to show them how to do injection into the piriform over here, okay? We're going to soften that area. In her situation, I don't have to make the nostrils much narrower than that, but I find that she's a little bit deep when you take a look from the profile, a little deep over here. So we're going to show you that technique now too. I'm trying to show them as many techniques. I'll do the eyes, and we'll do the lip flip, okay? And then we'll give you a break, and I'll do the other half of the face next week. No, of course. We'll do it after you have a little break, and I'll bring up the male so I can show some male stuff, okay? Does that sound good? Or maybe we can take questions while I'm doing it. Look where I'm standing. I'm practically behind the patient. I'm aiming for the opposite commissure. She gave me 0.3. I probably don't need as much. I probably need only about 0.2. I balance my hand over here, and I'm coming in right at the groove of the nose. This is one of the more sensitive injections, but I'm going to be gentle with you. Okay? I pull the nose back and in at the same time. And now I have to be down on bone. Can't get any deeper than that. Okay? We aspirate. 1, 2, good. Am I safe 100%? Never, so I'm injecting slowly. Very slow injection, maintaining the needle down on bone. Okay. Nice slow injection. Watching the skin of the area, looking up at the glabella. There we go. We're almost done. I love this injection because it really does dull things out in that area. I think I'm done. Out comes the needle, then goes pressure. I could have skewered an artery on the way down there, but I'm not in it if I'm sitting on bone. It's very rare that you should be it. How was that? That was the most sensitive. You can't say that was 0.
No, it wasn't 0.
So what was it? 1, 2, 3?
1.
1. You're still being nice. Okay. Good. You can see that it did narrow her nostril just a little bit, but that's fine. We can do a bunch of nose stuff. Do you want to do nose stuff? Yes. Oh my God. I did her nose injections also about 2 years ago?
Yeah.
Even, was 2 years? Yeah. And when did you have the surgery done? How long ago? Before you met me?
Yeah.
Yeah.
No. It was,
Yeah?
about 10 years ago.
About 10 years ago. So you knew me, but you didn't have it done with me. Okay. No problem. So, I won't take it out on you, I promise.